everyone, and welcome. Thank you for joining our presentation today, Billing for Article 29I, Office Hour. I'm Yvette Kelly with the Managed Care Technical Assistance Center, and I'm joined by my colleague Boris Vilgorin. Also joining us today is Tanya Rolson from the State Department of Health and Mimi Weber from the New York State Office of Children and Family Services. So before we get started, I'd just like to review a few housekeeping items. Just a reminder that this webinar is a follow-up webinar to the 3 pre-recorded webinars that were released that were in relation to billing requirements for Article 29I. So the slides and recording from today's presentation will be made available and accessible on our website, mctac.org, within the next week or so. As this is an office hour, we will devote a majority of our time today to answer questions. So we are asking participants to please submit your questions at any point during the webinar. You can do this by utilizing the chat feature located on the right-hand side of your screen. When submitting questions, if you can please use the drop-down box to chat to all panelists, that will ensure that we're all able to view the questions. And although we'll be answering a number of questions today, we would still like to refer you to the provider and billing manuals for official guidance. And again, as a reminder, as things are always subject to change, every effort was made to ensure that information and timelines are current as of today's presentation. So here's our agenda for today. We're going to start with a brief introduction of our state partners and then review some key elements related to timeline. We'll then move on to some commonly asked questions, and then we will open it up for Q&A and lastly leave you with some resources. So to get us started, I'm going to turn it over to Mimi Weber to start us off.
All of your colleagues, not only within your agency, but across the agencies throughout the state. So I just really needed to get on today's webinar to make a couple of pleas. The first is that contracting and credentialing with the managed care plans needs to be happening right now. We cannot delay. So you need to, really make sure that whoever in your organization is responsible for contracting and credentialing, that body of work is nearing completion with as many plans as you feel it's important to contract with. If you're running into any concerns, any questions, please do not hesitate to pick up the phone or send an email or a text or however you communicate with any of us, either at OCFS or at the Department of Health. Contracting and credentialing needs to be happening right now. Because you're quickly going to need to move into configuring your EHRs for the residual per diem rate codes and billing codes, as well as the other limited health services. So from a timeline perspective, you need to be focused right now on contracting and credentialing and immediately move into reconfiguring your EHRs to support the 29I billing. And again, we'll be in touch with you about the status of all those things, but I just can't impress upon all of us enough the importance of that body of work getting done right now. With that, I'm going to turn it back over to Boris and Yvette.
Thank you, Mimi. Appreciate it. So that brings us really to the purpose of today's presentation, which is really to review the billing requirements for services provided by 29I licensed health facilities. Just a reminder that the 29I facility billing manual has been released and is available for review. So hopefully you've had the opportunity to view that. You can find it at the link provided here. And please remember that the manual provides billing guidance only and does not supersede regulatory requirements or procedures. And so just to review, there are 2 categories of services that can be provided by Article 29I health facilities. These include the core limited health-related services, which are mandatory, and the other limited health-related services, which are optional. Today's presentation will focus on billing Medicaid managed care plans and, when appropriate, fee-for-service for the delivery of these services. We do know that there are some 29I health facilities who have opted into the February 1st transition date to bill Medicaid fee-for-service. However, beginning July 1st, all 29I health facilities will be required to bill Medicaid managed care plans. And a gentle reminder that providers should begin the process of claims testing to ensure that their systems are configured correctly so that you are ready to go on July 1st. So again, as Mimi said, this is a good time to be making sure that you're contracting with plans, and again, that you're doing some claims testing just to make sure that you're ready to go on July 1st. So we thought it'd be good just to start with some common 29I billing questions that we've received, just to really kind of level set and put people on the same page. And so we will review a few of them here. So the first question is, what happens on July 1st? Voluntary foster care agencies are required to obtain and maintain Article 29I licenses to bill for core limited health related services as well as other limited health related services. For those agencies who have not obtained 29I licensure, they will not be authorized to provide these services. Additionally, providers must bill Medicaid managed care plans for those children who are enrolled. So that is what's going to happen on July 1st. Uh, Another question is, will initial enrollments be retrospective to the first day of the month a youth enters foster care? For example, if entry to foster care is August 10th, would the effective month of enrollment be August 1st? And how would payment for services be rendered by fee-for-service providers between August 1st and August 10th be affected? So if a youth enters foster care on August 10th and is not excluded from enrollment, the effective date of the Medicaid managed care plan enrollment is August 1st, as long as the local Department of Social Services opened the Medicaid case during that same month. It is recommended that providers wait until the enrollment process is completed before submitting claims to the plan. Okay. So the next question is, do you need authorization from Medicaid managed care plans to provide core services? And the answer to that is no. The plan does not need to authorize for you to provide the core limited health related services. Do 29I facilities follow the same billing rules for CFTSS and Children's HCBS as any other agency, or are there differences when these are billed as part of other limited health related services? So 29I facilities must adhere to the CFTSS and HCBS billing requirements as outlined in the New York State Children's Health and Behavioral Health Services Billing and Coding Manual. And again, for quick reference, we have provided the link here. But again, these facilities must adhere to those billing practices stipulated in that manual. So the next question is, if the plans have a subcontract with Beacon or another plan for behavioral health services, do we bill Beacon or the plan for core services and for other limited health services? So for core limited health related services, they are always billed directly to the plan and not the delegate. All right, so in that instance, again, you're billing the plan and not the subcontract. For other limited health related services, providers really need to review their contract and talk with a plan, as this is different across plans. So again, communication is going to be important in this process. For core limited health related services, what diagnosis should I use? So providers should use an applicable ICD-10 diagnosis. If the youth has more than one diagnosis, then the provider only needs to include one diagnosis on the claim. If the youth does not have an identified diagnosis at the time of claim submission, then providers may use the ICD-10 code of R69. This, however, should be updated as soon as the diagnosis becomes clear. So again, if a child has multiple diagnoses, you're able to just use one of those diagnoses on the claim. If it's unclear at the time that you are billing for a service of what the child's diagnosis is, you can use the code of R69. However, this should be updated as soon as possible and should not be used indefinitely. All right, so the next question is related to the OPRA requirements and whether or not these requirements apply to the Article 29I facilities. And so again, the answer is yes, it does. If the individual licensed practitioner is Medicaid enrollable, they must enroll and use their individual NPI number on claims. If the individual practitioner is unlicensed or not a licensed enrollable Medicaid practitioner, then they can use the OCFS unlicensed practitioner ID. Again, links are provided if you'd like to learn more about the OPRA requirements or if you'd just like to find out whether or not you are enrolled. The next question is related to the OPRA requirement in that providers need to include their NPI numbers on the claim form. So the question that is often asked is what numbers do I include? And so just to review that briefly here, so field 56, the agency or program NPI number is required to be included on the claim. Again, all agencies must obtain an NPI number and link that number to the services and program in order to submit the claim for reimbursement. And again, if you need more information, you can find it at the link provided. For field 76, the attending provider, that is also a required field. Again, if the individual licensed practitioner is Medicaid enrollable, they must enroll and use their individual NPI numbers on the claim. If the individual practitioner is unlicensed or not licensed, they would use the OCFS unlicensed practitioner ID. And the other field here that is required is the field 78, the other provider or referring provider NPI number. So the referring NPI number should be completed with the agency's program NPI for core limited health related services as well as for other limited health related services. Again, this is the same requirement for both CFTSS and ACBS. So again, the referring NPI number should be completed with the agency's program NPI. The next question is related to the number of bills that should be submitted. And so the question is, if a child covered by a 29I facility shows up for a sick child visit, but the doctor is also able to address something unrelated, are two bills submitted? And so if the office visit covers both issues, there would be one claim for the duration of that visit. The claim would include the additional procedure codes to describe what occurred in the encounter, define the complexity of the visit, and support the time that it took to deliver those services. And so if the child goes into the office, I'm going to move on to the next slide just to kind of demonstrate. No, I'm sorry. I'm going to step back for a second. I think I went a little ahead of myself. So for example, if a child or a youth was a new patient with a moderate presenting problem, then the child or youth was seen for 45 minutes and the claim must reflect the following information here. As you'll see, so it has the rate code, the procedure codes, which includes the new patient office visit, the TB test, the services provided in the office during the off hours, and medication management, and all the relevant procedure codes, if applicable, and billable units. So you would include that on the claim. If that same child also received a vaccination during that visit, then the provider would submit a separate bill for the administration of that vaccine. So again, so you can see here all of the information that would be on that separate claim for that. So I think the important thing to remember here is that if you know, if if the services are distinctly different than from what the youth went into the visit for, that would be a separate bill. And that, again, that's the key, is whether or not the services were provided under that one example that we had given you before, if it was provided within that visit and the services were similar and can be attended to in that one bill versus if they were distinctly different. And that really leads us to the Q&A portion. And so we're going to open it up for questions. And just to say that there are, when you're able to have access to the slides, which will be, again, the slides and recording will be posted to our website. There are a number of resources that are included at the end of this deck that you will have access to. And so some of the links that we noted in the presentation, you'll be able to find there as well. And with that, I think I'm going to open it up for questions.
All right. Thank you, Yvette. I'll take it from here. And I also wanted to mention that we are working also on a billing tool. Some of you might be familiar with that if you provide also OMH or OASIS services, and so we want to continue providing guidance in regards to some of the fields, as Yvette mentioned during some of the common questions, and so forth. So more guidance or more information on that at a later time. So again, want to continue encouraging folks to chat questions in. We got quite a few already. I really appreciate that. Again, the goal here is to really hear from you guys and see, we'll try to get to as many questions as possible. So let's just start with the first question that came in. And it says, in the billing webinar, Boris, I guess I said something, mentioned that each claim, among other things, need a primary diagnostic code and a patient reason for visit code. Is the patient reason visit code a secondary ICD code, or are there some other lists of these patient reasons visit codes? So I guess what should go in a patient reason section of the claim, and is it just an ICD code, or there's some other list and so forth? So any guidance from, I guess, our state partners on that?
Yeah, so both of those codes are going to be the ICD-10 codes.
Great.
And so we will have links in the billing tool, right, Boris?
Yes, we will, definitely. And but it doesn't have to be necessarily secondary or primary on the reason, right? I mean, they could be the same, or they could be the same. Okay.
That's correct.
Thank you for that. All right. Next question is about lab work and around modifiers of U9 and SC. It seems like some lab work also requires QW modifiers. And so the question is, should providers look these up themselves, or will a list of the labs in the billing manual that require QW be provided? And is the QW modifier supposed to be listed first?
So all the modifiers that are listed with all the procedure codes and the grids in the billing manual is what you need to bill. So you don't want to go looking for new modifiers. And there is an appendix in the end of the billing manual that gives you the modifier descriptions to let you know what we intended, gives you a little bit more context for what the modifier is. The order of the modifiers doesn't really matter. You just need to make sure that you have them both. So if it has two modifiers, you need to include two modifiers. If it has one, you need to have one. So it's not an either or. And specifically to, I'm just going to look up, I don't recall having a Q modifier. So let me take a look at that in the labs and I'll get back to you.
All right. Thank you. So the next question is about CPT codes, and I guess the question is around non-billable, and if a CPT code is not listed in the guidance as a non-billable, can providers still include it in a claim?
Yes, you can, for non-billables, you can include any numerous CPT codes that you feel are appropriate. I would, refer back to the AMA guidance on that, on what that code is used for. We tried to capture the most common codes that we think that you'd be using based on historical service delivery and, many work groups at this point. So if there's something outside of that, non-billable, you're free to add. For billable, you get exactly what we have in the book, and so you wouldn't be able to bill anything outside of that.
Got it. Thank you for that. The next question is about making referrals to specialists. And so the question is, will 29I agencies, especially those who act as a primary care providers, be able to refer kids to specialists?
Mimi, do you want to take this?
Mimi, you might be on mute. I'm not sure.
Maybe.
Just, let's see if.
Can you hear me now?
We can hear
Yes.
you now. Yeah.
Yes.
Thank you. I'm sorry about that. Double mute at least once a meeting, right?
That's right.
I'm sorry about that. So yeah, this is a good question. And I think the quick answer is that it's going to depend on the plan in terms of what the plan allows for and requires. So if you are the primary care provider, certainly you can make referral to specialists. If you're not the primary care provider for the child, I really urge you to go to each of the plans that you're contracting with and understand what their policy is on whether or not a physician who is not the child's primary care provider can make a referral. I think what I'm hearing from many of the plans is that for this population, they're allowing the 29I agencies to make referrals to plans, but that's not a guarantee. You need to know what's in your contract with your plans.
Yeah. And I think, also probably good to mention to make sure that the specialist is in network, whoever you're making, if you are able to make referrals, whoever you're making referrals to. So I think always good to work with the plans and all of that information. So thank you. The next question.
Hold on one second. I can go back to the Q modifier in laboratory.
Yeah,
I'm not seeing any association with the Q modifier. So if somebody has a question on that and they can point me to a reference, I'm happy to answer. If you can just email me at the bh.transition@health.newyork.gov, I'm happy to answer it.
Excellent. All right. Thank you for that.
I just for folks to know, I just changed the slide so that you can see that mailbox.
Good. Thank you, Beth. The next question again is about physical, how many physicals can a child have per year, and if the plans will honor more than one. Especially there's a mention about ACS for foster care children. Would it be? Yep. Go ahead, Mimi.
Yeah, sure. So the policy paper that was released now several weeks ago is very clear that children that are placed in foster care often have needs that exceed the general mental health, the general Medicaid population, and that the plans are required to pay for any mandated or required assessment as determined by the county, the 29I agency, or the state, OCFS, or the Department of Health. Included in the policy paper guidance that was issued, speaks to the fact that kids in foster care often see the doctor on a more regular occurrence by virtue of their foster care status. So the plans should be honoring any assessment or diagnostic evaluation that a child might require, whether that's mandated, required by any governmental body or the 29I agency.
Excellent, thank you on that. And maybe we'll stay something similar. There's a question about ECGs, and a particular agency does a lot of ECGs, especially around psychotropic medication. And they just want to make sure that, because there's a language in the manual that talks about you can only do this as by a triggered event to diagnose. And I guess the question that came in is with kind of doing ECGs around treatment with stimulants or psychotropic medication be considered or acceptable trigger event? It's pretty detailed, but I'm not sure if we can answer it right now.
So, I mean, I can give you a general for all mandatory assessments and or medically necessary assessments. You're going to be able to do as many medically necessary assessments as you need. So, as long as you can support that in documentation, there shouldn't be an issue. And I agree, Boris. There's probably a lot of nuance there, right? So, is it a mandatory assessment? Is it a court order assessment? Is it just something the kid needs and is medically necessary outside? Is it both? So there's a lot of there are a lot of reasons why a kid would have multiple of any of the assessments and or office visits for this population, and the state and the plans and the providers are all aware of that.
Okay.
Yeah, and
Thank
Tanya
you.
and Boris, I would just add to that if there's a concern about payment because you think the plan might look at a service as a duplicate, give the plan a call. Let them know that this bill is coming. This bill is coming because it's a required or mandated assessment or a required or mandated or medically necessary service. So give them a call, give them a heads up, stay in that communication with the plans if you have any concerns.
Yeah, I think that's always, a great advice. And I think that the more you can communicate, I think one of the things that sometimes, trips plans is the terms like we do this routinely with everybody. And I think their question is usually back to what me was just saying. Well, is it medically necessary for everybody? Is it required or mandated by some entity that you're doing this? I think sometimes if it's just a matter of practice, might be a little tricky. But again, if you have that communication with the plan and have a discussion about your reasoning, the thinking about it, that might, be okay with them. And especially if it's required by, as a mandated service or something like that. But yeah, otherwise, again, just have a conversation with them. So I think, always good to have that. So thank you for those answers. So there's another question about core services and the NPI number. So again, the comment is, core services are provided. There might be multiple individuals during the period that provides the service, who should go, whose NPI should be used. I mean, my understanding is there's no magic to this. It's really for agencies to determine this. I know some agencies for things like core services have decide on a particular person that they kind of always use or have some sort of a algorithm they utilize in regards to NPI numbers and choose. And so there is a number of approaches. I don't think there's a state requirement besides that there has to be an NPI number, but I don't think there's a requirement on whose NPI number goes there. So, but I just want to check with our state partners if that is accurate.
This is Tanya. That is accurate.
All right, thank you on that. Okay, there was so just want to let you know, as Yvette said, we, the slides do have links to many different things, including the billing manual, but there was a request to put it in the chat. So if you're interested, there's a link to the billing manual in the chat as well. So the next question is, what is the difference between 0519 and 0529 revenue codes? Which one should, an agency use? So again, I'm not that versed in codes yet. I don't speak code that much yet, but I don't know if anybody else knows. If not, we can come back to this one.
There are specific revenue code descriptions. Honestly, it's up to you guys which one you use. Let me take that back though and see if I can update with better descriptions, because I do believe I just listed them. I did not. I mean, you can find them on the web, I'm sure, but let me get some more information on that.
Okay, thank you. Let me just see, just kind of going through other questions. So please feel free to continue submitting your questions here. So just a question I know that came in also about how many claims should be submitted. So if I'm doing other limited service and core and have to submit, use the same, it's this on the same date, is it two claims or is it two claim or one claim? So any thoughts around there?
Sorry, but Boris, didn't follow the whole question. Can you just repeat for me?
Sorry. Yep. Yeah, no, of course. So if I have to bill for other limited services, let's say, one of the psychotherapy or something else I did, but also a core service, those would be, I suspect, two separate claims provider would be submitting. It doesn't go on the same claim.
Correct. Yeah, so for core services, the core per diem, if you had a kid in care for 15 days straight, you could bill those 15 consecutive days on one claim. That's really the only instance where you can combine claims. If you have a core claim and an other claim, those have to be separated. If you have two other claims that are both billable, so you had an office visit and a lab, you're going to want to separate those claims because the first one will get paid and the second one won't if you do not separate the claims.
Got it. Okay. Thank you on that. We got a question around just clarifying, kind of who bills when. So there are a number of agencies that are also, in addition to 29I, have Article 28, maybe Article 31, both. And so the question is, could those agencies still bill for children and youth who are in foster care through Article 20? 8 or 31, or is it all have to go through 29I?
Mimi, do you want this one?
I'm sorry, could you repeat it?
Sure. So I guess this is outside of core because core would only be 29I. So I guess the question is, could agencies who have multiple licensure, including Article 28 and 31, still bill under those licenses for services provided for children that, are in foster care?
Yeah, it's a great question, and the answer is yes, of course. Just because a child is placed in a foster care agency that is also in Article 29I doesn't mean that the child needs to receive all of their health care services there. We certainly expect that children will continue to access services in Article 28 and Article 31. The important piece to keep in mind here is that we do not expect to see children accessing the same type of service. So if a child is receiving psychotherapy through the Article 29I, we would not expect to see a child going to an Article 31 for this to meet a treatment goal that's the same as at the 31 that's already being provided under the 29I, or vice versa. So there's no duplication of services. Now, another example might be the child's on medication and the Article 29I is managing the medication, but the Article 31 is maybe doing the psychotherapy. That would be an acceptable reason why we would see a child in both service settings. But the rule of thumb is we're not duplicating services under more than one authority. And Tanya, if you'd like to add to that, I'd appreciate it.
Nope, totally agree. And that there is a section in the 29I Health Facility Billing Manual that describes concurrent billing. So we do provide an example, and it was very much like what Mimi just said.
Excellent. Thank you for that. I know Yvette went through one of the authorization questions, but we still have another question around when authorizations are required. So again, just reminding folks, for core services, authorizations are not required. This question is specific to clinical behavioral health services. I think the answer is, you really should be in touch with your plan to kind of think through and find out their processes in regards to authorization, and if they would require specifically if it's around clinical behavioral health, but all other limited health services as well. I don't think there's a one document or one place. I think each plan has their own kind of process to that. Is that accurate?
Yes, that is accurate.
Okay.
The interaction between the 29I Health Facility and the managed care plan is going to be really, really important here. So getting your liaisons ready on both sides is vitally important for this transition to be smooth. It's also going to be very important to, reduce frustration around what the expectations are, and in order to educate each side on those expectations. So you guys will really need to rely on your liaisons and communication between each other.
Got it. Thank you. There's a question about what billing form is applicable for field 56, 76, and 78, which is NPI. Not sure what that might be reference to. I know in general, the billing form we're talking about that providers need to use is 837I or UB04, depending if it's electronic or paper. So I'm not sure if others might know what that might be referring to.
I am not. I would agree with you. The UBO4 837I are the two references to forms, but I'm not sure specifically to a field what that means.
Okay, thank you. All right, let me just see other questions. All right, I know we have a couple of really detailed questions. I'm just, there's a question around psychotherapy and kind of minutes, kind of ranges and what could be more or less in units. So any general, I guess, guidance, or I know there's a lot in the billing manual that could be provided. So I guess the question is how many units folks will bill for, because there's this breakdown of minutes.
Yeah, there is a billing, like how much time used or how much time in an encounter, and how to bill, like how many units you'd bill per minute. There is a chart in the billing manual. I don't know if that's helpful to this question or if there's something else being asked, but I would refer back to the chart. It has like 0 to 7, 8 to, and then so on. And you just find the line that falls in that time frame and bill that many units.
Right, and I think there is one unit there, right? I think the question is what is the minimum number of units that can be built? I assume it's one.
Yes, that's correct.
Yeah, I don't remember the minutes that it reflects, but yeah. But all right, so I think that might be the question there. If not, please chat in, maybe a little bit more on that. Let me just see if we got anything else. Okay, so in regards to the minutes, with it again, is there a rounding of minutes allowed? I guess probably not, since it's very specific.
Yeah, I mean it also does have a range. So once you hit the minute, once you hit the next minute and the next range, then you build the next number of units. So no, not a rounding, but there is a range.
Got it. Yep, thank you. All right. Another question in regards to number of claims to submit on a given day or services. So, we talked about, Yvette went through an example with kind of the office visit and then vaccine provided, but there's also a question about what if I do a primary care visit and psychotherapy, for example, or behavioral health visit. My assumption always is it's two claims if it's two different rate codes. And so those tend to be those in that example of primary care and behavioral health. I just want to check to see is accurate.
Yep, that's accurate. So if a kid needed to see a doctor for a physical health claim and also needs to see somebody for a behavioral health claim, they're on two different claims, and that would be appropriate.
Excellent. Thank you for that. Great. Just flipping through to see if there's additional questions here that we might have missed or haven't gone to. Yvette, is there anything? I mean, I'm not sure if you notice anything. Just want to make sure.
Yeah, so there was a question that came in around, let me just see if I can find it real quick. It's a Medicaid ID question. Are downstate youth going to continue getting foster care Medicaid numbers? I'm not sure. If not, will we be able to use the community Medicaid number for billing to ACFs for services?
Yvette, could you repeat that again?
I sure can. Yep, it says, are downstate youth going to continue getting foster care Medicaid numbers? I'm not sure that's how it's framed.
So let's stop there. Yep, let's try to break this question down. So the
Okay.
answer is we're not. This transition is not changing the Medicaid eligibility process for kids that come into the child welfare system. So we know in New York City that when children enter foster care, ACS establishes a new Medicaid SIN number on the upstate WMS system. That process is not changing. Yvette, can you read the second part of the question?
Yep, the second part of the question says, if not, will we be able to use the community Medicaid number for billing to ACS for services?
Well, we don't bill ACS for Medicaid services, right? We bill eMedMe or we bill the managed care plan depending upon the child's status. So I'll repeat again, when a child enters foster care through New York City, ACS establishes a Medicaid case through CIRMA. That CIRMA process creates a new Medicaid SIN on the upstate WMS system. You will use that SIN to bill either eMedMe if the child's not yet enrolled in a managed care plan or otherwise exempt or excluded, or if the child is in a managed care plan, you will bill the managed care plan. It's important that you check e-PACES on a regular basis to verify the child's Medicaid status. And if the child's Medicaid is not established properly, you need to contact the county immediately. In this case, it seems to be ACS. Why this is important is because Maximus, the enrollment broker, the managed care enrollment broker, or Medicaid Choice, whatever you want to refer to them as, will be pulling a daily feed of new kids coming into foster care, and will be making recommendations to the 29I agency about plan enrollment. That'll be based upon, in this case, in the ACS situation, on the upstate SIN, the new SIN that gets established. So the answer is no, you cannot bill using the downstate SIN. And Tanya, if you want to add to that, I would appreciate it.
Yeah, I don't really have anything to add. I just emphasize that we're not changing the process there, like Mimi said in the beginning here. So I think whomever wrote that question, if they have more questions or more detail to that question, please send it into the BH transition box, and we will either try to answer it directly or have a call.
Excellent. Yeah, thank you for that. And I just wanted to underscore Mimi's comment in regards to using e-PACES and checking on eligibility. We just did a panel discussion with managed care and been talking to managed care, and almost it seems on all transitions or most transitions in different fashion throughout the state, and we actually do some work around the country and see this in other states as well. One of the main kind of issues that comes up during transition is this eligibility. And New York is actually one of the places where it's relatively easy to check. It's not always, 100% accurate, and there's always issues with it, like any system would have. But, the checking of eligibility, seeing if somebody is in Medicaid, fee-for-service versus managed care, and which managed care plan is crucial, because one of the main denials that comes up in any transition is this, the billing to the wrong payer, being directly to Medicaid or to managed care and so forth. So I just wanted to really emphasize that point, in regards to billing and setting up your system. And many EHRs actually have a nice way of communicating with e-PACES and checking eligibility automatically. And so, also would encourage people to set up those systems that might help you with more batch processing rather than looking up each person separately. But thank you for those questions. Any other thoughts? Because not sure if I'm seeing any more questions, but other areas that folks wanted to touch on or.
So, Boris, I'm seeing a question coming in. Who should we reach out to if a child is missing K codes on e-PACES? we're not using K codes for foster care anymore. K codes are only now being used for purposes of HCBS.
Yeah, and I've gotten a couple of questions in the K codes, and I K5 is DD foster care, but again, I want to reemphasize that is just for eligibility for children's HCBS. It just means that they're eligible for children's HCBS and they should be receiving HCBS services. It does not have anything to do with their foster care status or their placement in foster care or any of that.
Excellent. Thank you for that. Yvette, have you gotten any other questions or see anything else on your end? Because I know sometimes we'll get questions coming in different ways.
Yeah, no,
But can we go back to this question for just a second? So
Yeah.
if the child is missing an HCBS K code
Thanks, Mimi.
for whatever reason, yeah, you want to take it from here?
Yeah, I was just going to say the same thing probably. So I was going to say if you are missing a K code for some reason for HCBS children, you know that they're getting the service or you know that they're eligible, I need you to reach out to the capacity management mailbox. If you don't know where that mailbox is or you're not sure what it is, you can use this BH.transition box and it will be forwarded to them directly so that we can figure out what's going on with that.
That's great. Thank you. Okay. Sorry, Yvette, were you gonna
yeah, no
jump in here
question.
too?
Yeah, I don't think that, I think those were all the questions. I'm not seeing any additional ones.
Okay. Yeah, thank you for all the questions. So please feel free. We do have a couple of more minutes. So if there's any additional questions, please feel free to chat more. And Yvette, I think we also have, like with, there have been links throughout the presentation, but I think that we have a couple additional slides that have resources past this. So just wanted to point, that there is a number of slides with links to many resources for folks to access when these slides become available. So I just wanted to point that out as well.
And Boris,
Absolutely.
I'll also put in a plug that we're going to do, OCFS will be hosting another Medicaid managed care liaison training for the 29I agencies. The next training session is going to be March 17th. We added that due to popular demand. So, reach out to OCFS if you have not received the WebEx and would like to. We will repeat the session on March 2nd, April 13th, May 4th, and June 1st.
Excellent. Thank you for
Another
that.
place where questions can get answered.
Okay, that's great.
And Boris, as you mentioned, there are a number of resources that are at the end of this slide deck. So when you're able to access them, you'll have them. They come with a number of links. As you can see, I'm scrolling here. So again, a lot of good information that you'll have access to.
Yep. And also, since we're plugging things, I want to plug that, pre-recorded webinars that we've done recently and were released as well. Please take advantage of those. They're part of the resource page here. So really, please take advantage of them. And they're, on our MIGTech website, and they were emailed as well. So.
And Boris,
Right.
I'm getting another question,
Yep.
and maybe it's a clarification that has not impressed upon me, but someone is sending in an email saying that Health First is one of the only Medicaid managed care plans that uses HCFA 1500 rather than the UB 404. Can you confirm or clarify that?
Yeah, so the 1500 and Tanya, I believe that's not applicable for Article 29I services, right?
Well, that's correct.
Yeah, so yes, that's something you might want to follow up maybe with Health First on that, because for 29I, they should not be using those or telling providers to use those claims.
I'll make note of that for the review, Mimi.
Yeah.
Thank you.
Yeah. Now there are other services, that might be, but not within 29I or CFTSS or HCBS, or honestly anything that at least we at MIGTech have done in probably the last 4 to 5 years. So, but thank you for raising that.
Great.
Yeah.
Yeah. I didn't. Dave, our good friend Dave, is raising it. So thanks,
Okay.
Dave.
Yeah, no, thank you. Yeah, that's important. And that's part of the back to the testing of their claims, right? That's another way sometimes you might find out certain rules or nuances with each plan accurately or inaccurately, but you want to do it now rather than after July 1st. So if you submitted them, you know, a UB04 or 837.9 and they kicked it back and said, no, it had to be 1500, this then allows you to have that communication with the BH transition box, letting them know and try to fix this beforehand. Or if there's actually, you know, things that, you know, maybe your system or their system is doing it correctly. So again, you know, a real, another reason why claim testing is so crucial, because you can uncover some of these nuances and issues. So I don't see any other questions coming in. So I don't know if Mimi or Tanya want any last minute words before we close today's session.
Yeah, I just want to clarify that the OCFS will be offering the next Medicaid managed care liaison training to the 29I agencies on February 17th. And then the next one after that will be March 2nd, April 13th, May 4th, and June 1st. Sometimes I get my months mixed up and I'm not sure if I was 100% clear.
Got it. All right.
But other than that, I just want to thank everybody for attending.
Thank you for all participating.
Coming in.
Yeah, thank you. And I want to thank you to our state partners for answering the questions and being part of the presentation. So thank you, everybody. And thank you for joining us and have a great rest of the day. Take care, everybody.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.